who decides that the life of the mother is at risk? Because that's what we're talking. We're not talking just health. We're talking life. But then when you talk health, well, what about is mental health part of the health equation when you say the health of the mother? Right. And so it gets really hard to get a good consensus on those issues so that the doctors practicing here aren't practicing in fear.
Representative Vander Woude, how are you?
I'm doing well.
Good. Thank you for coming in today. There's a lot that's going on that health and welfare, which you're chair of, you're at the center of a lot of things, especially with the GOP platform priorities that came out after the convention. A lot of stuff going on here. So again, thank you for coming to chat about this stuff. Let's just fire off with the first one, which is Medicaid expansion, if that works. And again, health and welfare deals with Medicaid. We have seen a ballooning of costs around Medicaid for three particular reasons. It has been the number of people taking it, right? Because you can be up to 26, the amount of cost per person, because we get reimbursed from the federal government, but that reimbursement percentage has been decreasing. And then we have more people in the state. So we've increased the breadth of who can apply. We've increased the cost of the state of Idaho, and then we've increased the number of people. Is that accurate?
Well, we actually last year, because that Medicaid expansion, and they froze all the determination of whether you were eligible for Medicaid during COVID. Mm-hmm. So once you were eligible, you were never declared uneligible through COVID, through the whole pandemic. And so last year at the start of the year, then the pandemic, quote unquote, ended. And so then we had to redetermine whether these people were still eligible. Mm-hmm. And so we had to go through that whole redetermination process, and the federal government was watching how we did it, didn't like some of the stuff we did, but we took about 100,000 people off of Medicaid.
Oh, so we had a net decrease.
So we had a net decrease.
Gotcha.
Now, some of them have come back on because some of the response of why we took people off is we sent them a letter saying, hey, you need to respond to this letter that's to see if you are still eligible for Medicaid. And I think like 70% of the people didn't respond. Mm. And so they were automatically off. Well, once they found out they were off, then some of them re-enrolled and got back on again. So I want to say maybe 50, 60,000 less on Medicaid now than what there was last year at this time.
Gotcha. As far as a reimbursement from the federal government, because again, the expansion happened, at least it's my understanding, because of the mandate coming from the federal government. Is that correct?
No, that was a voter initiative.
Okay.
The voter initiative. The federal government gave us the option if we wanted to expand or not.
Okay. I'm sorry.
Idaho did not.
Gotcha.
But then they had an initiative, and Reclaim Idaho ran a ballot initiative, and the people voted to expand.
MTU Studios is the proud producer for the Ada County Sheriff Podcast, the Idaho Wildlife Federation Podcast, the State Representative Ted Hill Podcast, the Idaho State PTA Podcast, and many more. If you or your organization is thinking about starting a podcast, MTU Studios would love to help. Just check out mtustudios.com. Gotcha. So the federal government gave us the option.
Right.
Idaho declined. And then the voters of Idaho said, no, let's go ahead and expand.
We want to take that. Yeah.
Gotcha. Why has the amount that Idaho covers in this healthcare cost, why has that been increasing?
I think there's more people on it than what they originally estimated, and the cost of all medical has gone way up. So when this initiative was proposed, it says it should cost about $400 million, and Idaho has to pay 10%. Because it's a 90-10 pay from the federal government. So Idaho has to pay the 10%. So it's only going to cost Idaho $40 million.
Just a quick $40
million. And we were already paying some of that in the Indigency Fund and the CAT Fund, where we were covering some of the cost of people who couldn't afford some of their medical bills.
Gotcha.
But now that cost has ballooned to over $1 billion. So now it's costing us $100 million, not $40 million.
So that percentage, the 90-10, has stayed consistent.
That has, yes.
But $40 million to $100 million is a 250% increase.
Right.
Right.
So it got sold as it's a net cost. We're going to save money. And it turned out it hasn't saved us money. We are spending a lot more, even our 10%. Now that expansion is a 90-10. The other Medicaid, the normal Medicaid, is about a 71-39. And so for the standard Medicaid, not the expansion group, we pay a higher percentage of the costs.
Okay. Has the normal group, the 71-29, has that also expanded in cost and number?
That has, and also because the federal government determines what your rate is. Not everybody's the same. So depending on how well your economy is doing, what your wages are, and some other factors they put in there, they determine what percentage that we have to pay. So last year, ours went up from, it was like 69, almost 70 to about 71. So it was 1.5%, I think, or maybe 2% it went up. And we had to pay a higher portion of that bill. And now this year it's going to go up again. And we're going to have to pay, probably it's cost us another $30-40 million more of general fund money for the same cost.
Gosh, man, that's
so
you
think as your economy does better, the federal government figures the state can pick up more of the tab, and the federal government picks up less.
Gosh, man,
yeah,
that's rough.
What is, because automatically, I mean, if you don't increase cost, we have to put in another $30 million of general fund dollars just to cover if the cost never went up.
Gotcha. And what can Idaho do to curb this? Because obviously the GOP platform is talking about ending Medicaid or Medicaid expansion, right? Not Medicare.
Yeah, no.
Yeah. Okay.
Yeah, they want to end probably Medicaid expansion.
Great. So that's the 90-10.
That's
portion.
the 90-10, yeah.
Okay. And do they want to touch the original group?
I don't think so. I think most people realize that there are people in need. There are people that need some help. And so, because the Medicaid expansion was for able-bodied adults and everything. Well, if you're able-bodied under the unemployment rate, that's, right around 3%, you probably can find work.
Gotcha. Yeah. So the idea is like, all right, this was going to be just a quick $400 million price tag, of which Idaho picked up $40 million, but it's over $1 billion. And
Idaho's picking up 10% of that, so you're talking $100 million.
That's a lot of money.
And the budget was $887 million last year, but the total costs were over $1 billion. Because my projection was that next year it was going to go to $1 billion. It wasn't, but we have already hit the $1 billion in this year.
What's the projection for this coming year?
I haven't seen the new budget proposals, but I'm going to guess it's probably going to be 1.1 or 1.2 billion, because we've already crossed the $1 billion mark.
Right.
And this year's funding.
Gosh, I mean, I'm trying to just wrap my head around it. That's a dump truck of money. So the idea is, okay, look, let's stop the expansion, and that could be done through a voter initiative.
Well, it can be done through legislation too.
Okay.
So we had a couple drafts of bills to repeal Medicaid expansion.
Gotcha.
And so the legislature, we couldn't get it out of our committee. We were one vote short of getting it out of our committee.
And what are the arguments for keeping that in? If you're an able-bodied individual, I understand there's the argument that it's, hey, up until 26. And look, I understand that, different people have varying capacities in the world to, fend for themselves and fine. But at 26, I had owned my own business for like 4 years, and I was married. And like that, I understand perhaps I may have been ahead of the curve or different from my age group, but I mean, 26 is, you've had 8 years since you graduated high school. So was there a big argument towards really needing to help the young adult category, or what's the argument towards keeping the expansion? The
argument was that prior to Medicaid expansion, the counties were picking up some of the indigent fund money up to a certain amount, and then the state was picking up the rest of it that people couldn't pay. So there always are people that have a medical emergency that they couldn't foot the bill on. And so I don't think it was ever intended to take away benefits that people need or have a safety net somewhere. But what I really think the real problem is we don't have a program that transitions you off of Medicaid and back into the private sector. You can go on the insurance exchange, and I want to say about 40% of the people on the exchange don't pay any premiums. So you can get on the exchange, and so there's got to be a bridge that takes people from Medicaid onto private insurance, even if it is on the exchange. Now, some of the argument that people have given me is like, well, yeah, but that isn't as good a coverage on the exchange, on the policies that they sell there isn't as good as Medicaid, because Medicaid, you don't have to worry about any of it. And that's true. But at the same token, I think we need to have a bridge. Now, we originally, in one of the waivers that we asked for when we did Medicaid expansion, was that people in a certain category, if they were between 100 and 125% of poverty, because that's what decides, percent of poverty decides whether you're eligible, that people between 100 and 125 would have the option to go private insurance or stay on Medicaid. So it would create that bridge that people could, move on up and get into the private insurance, and the federal government wouldn't approve that waiver. We may try that one again and put it out there, because to me, you got to have a bridge. You can't just have a cliff.
Right.
You can't have that you get so much, and then if I make a little more, I lose Medicaid, but now I don't have insurance.
Right.
And so there's got to be a timing that you can bridge that gap between Medicaid and private insurance.
Gotcha. A question about something you brought up, that it's not a question of if people will be denied care, right? Because if I don't have insurance, pre-Medicaid expansion, say I'm 24 and I don't have insurance and I get in an accident of some sort, right?
Yeah.
And I roll into the emergency room, they're not going to ask first, like, okay, where's your insurance card, or get back in your car and go away, right? They'll give me care. Now, in the event that I cannot actually pay back that care in some way, or the bill's astronomical, say I have a compound fracture in my forearm or something, astronomical bill. What portion of that bill did the state of Idaho eventually have to pick up? Because the hospital incurred a cost, the doctors and caretakers incurred a cost, and they have to at least in part be made whole. And generally they take a haircut on that.
And that's what we did with the Indigency Fund. The counties picked up part of it, and then the state picked up the balance to keep the hospitals somewhat whole. Because, they can't deny services. You come into emergency and stuff like that. Now, we've tried to do some of the Medicaid preventative stuff, and that's where you get the argument. Well, if we do Medicaid and we do the preventative, then we don't have the high costs coming in, because they never showed up, but they're diabetic, or they got some other issues. They got a heart condition or something like that, and they never showed up anywhere. And now all of a sudden we got a $500,000 hospital bill.
Right.
And so the idea was that let's keep these people in and get them taken care of ahead of time. And so we've done adult dental, that's expansion, much to my chagrin. But anyhow, so we did adult dental for Medicaid. And I've talked to the director, and he says, well, maybe we do adult dental is only available if you start doing some of the preventative steps.
Right.
In other words, we will provide it, but you have to do your regular checkups. In other words, you got to have some skin in the game if you want us to continue to do dental.
The skin in the game is one of the things. I was speaking with somebody from Ada County just yesterday, and the skin in the game is it's almost like people don't want to engage in asking something of the citizenry as the citizenry are getting things. For instance, there was an initiative through, I believe, Boise to deal with homelessness, right? I think it was like the Red Line, and right. And so it was a dump truck of money, like an astronomical amount of money to rent. I think it was like 32 rooms at this hotel, essentially, and house homeless people. And there was no ask. Right. There was no like, hey, you got to get rehab. Hey, you can't do drugs here. Like, hey, you got to clean up your act. And people really didn't like that. Right. Especially there were some individuals at Ada County who were like, listen, we need to be doing something. Right. And the obvious opposite option is there are several nonprofit institutions, Christian based or whatever might be, that always have open beds. They always have resources available to people. But the problem is the people have to have skin in the game. they actually have to get, go into rehab, or they have to clean up. It's not an open air drug scene. You can't go to these places and just start, smoking or doing whatever it is you're doing.
Yeah.
And people get very, very leery about providing service with strings attached.
But it's, you almost have to. I mean, Boise Rescue Mission does a great job, but they have open beds, but people don't want to go there because they have restrictions.
Right.
And so, and I've talked to another legislator who works in the medical field, and they said, the people on Medicaid are the most demanding because they expect services now and expect to get them right away. And I was explaining to them, I had last year, I had a dental appointment for cleaning, couldn't make it. And so the next opening was a year later.
Wow,
but
you have an in-demand dentist, man.
Yeah, and it was like, well, that's the way it is. But a lot of times people on Medicaid think, well, I just got denied because I'm on Medicaid. But there isn't enough providers for everything either.
Right.
And a lot of the providers will only accept so many Medicaid patients because of the reimbursement rate.
Right. Which is just a hard reality of the world, right? Like if you're a dentist, you can... my dad's in the health world. He's a physician, and he struggled with this thing too. Not struggled with it as in he denied people, but he recognized that it was a large trade-off, and he would always care for people, regardless of their insurance. He wouldn't gouge people that had private insurance and then, accept a lower rate. And because of that, people frequently sent, quote unquote, less desirable reimbursement patients, right? It's not that anything wrong with the patient, but just the way he was going to be compensated was less favorable. That's just the way it went.
Basically, you would probably lose money on it.
Right. Speaking of providers, this is a real problem in the area. Not just before the GOP convention, but providers of female health care, right? And especially after the GOP convention and the repealing of Roe v Wade, and then Idaho making its own determinations of what it wants to do with abortion, right? You do have exemptions in the case of rape and incest and, health of the mother. Just that step, I've been told, really drove out a certain portion of female healthcare providers because they're like, listen, I'm not interested in engaging in this. I don't think the government should be involved in the room when I'm dealing with my patients. What is being done or is anything being done on the state level to encourage more healthcare providers to come and work in the state?
Well, I've had several conversations on that, and we had some drafts of some possible legislation, but everybody was holding up, waiting for the Supreme Court to decide on our abortion restrictions. Now the Supreme Court kicked it back to, I think, the Ninth Circuit again, and we'll kind of see what happens. But I've always been of the philosophy, because it's the, rape, incest, or life of the mother.
Excuse me, life of the mother, not
health.
Yes, different thing.
But to me, I'm pro-life. But the life of the mother is important too, just as much as the life of the child. And so I felt like there had to be some guidelines as far as the health of the mother goes, but drawing those up I found to be extremely difficult.
Right.
Because every now and then, you think, well, no, that should be, and then no, that somebody sees it differently, and so we've not been able to reach a consensus. And like I said, we didn't do anything last year because they were waiting for the Supreme Court, and now that's still not final. But the problem with that, I think, in my opinion, and I'm just going to give you my opinion, is that you can't practice under fear. And that's what some of the OBGYNs are doing, is they don't know what the guidelines are exactly. And so they're afraid that they might get trapped or get sued on something like on doing an abortion. So it has to be clear what the guidelines really are, where they are, so that any of the doctors that are coming here or that are practicing here know exactly where their limits are, what they can and can't do. And I just don't think it's that clear in the law, because life of the mother, when is the life at risk? Who decides that the life of the mother is at risk, because that's what we're talking. We're not talking just health, we're talking life. But then when you talk health, well, what about is mental health part of the health equation when you say the health of the mother? Right. And so it gets really hard to get a good consensus on those issues, so that the doctors practicing here aren't practicing in fear.
Yeah. Yeah, because I mean that's just
you just can't you can't practice, and the bigger hospitals, they've got enough lawyers, but you start getting into the rural areas, and if you're going to be a doctor out there, how much coverage do you have? How much protection do you have if one thing goes wrong and somebody goes after you? And so I think in the rural areas it's even worse, because I think St. Luke's, St. Al's, they have probably enough staff to protect their doctors, but start getting the rural areas, I think it's be a lot more difficult unless it's clearly defined.
Gotcha. So the legislation that you guys are trying to flush out is giving more clarity and guidance about what is appropriate what is legal versus not legal,
right?
And then going from there.
Yeah, and trying to get something. I've asked some of my Democrat friends in there, draft me something that you think we can get through. Not necessarily what you want or what you would like to have. Because some of those might like a lot less restrictions than what I would like. But at the same token, you got to try to get legislation that you think can work through the process. What do you have a chance of getting through?
Gotcha. Is there any, and again, I have no idea if this is even possible through the Health and Welfare Committee, but is there any discussion about not necessarily liberalizing, but helping medical education systems produce more and, I wouldn't say better. I mean, we have good doctors, but just more doctors out of the population we have. I mean, obviously going to medical school or nursing school is very rigorous and difficult, also very expensive and time consuming. And we're lacking, again, as you're saying, we're lacking providers, we're lacking services. And, obviously we can let the free market, we say, all right, well, let's pay our doctors more here in Idaho and, great, we'll get more doctors. Well, I, as an individual, I can't just pay the doctor more, right? Like, I got my copay. I could tip him. That would be awkward.
Yeah. But, bring him a chicken or some eggs.
Yeah,
or
right.
Something.
But like St. Al's, right?
Well, it used to be, yeah.
Yeah, right. St. Al's, like I can't affect St. Al's. Like I can't tell St. Luke's like, hey, pay them more, right? They don't care about me at all. So is there any discussion about like, okay, how do we generate more medical professionals in the state of Idaho to serve the state of Idaho?
The biggest part of the problem is there isn't enough opportunities. I've had friends that waited 4 or 5 years to get into medical school to become a doctor, even though they've already graduated and they're at the top of their class or close to it, and they can't get in because there's only so many openings.
Sure.
And so Idaho expanded some of their residencies and try to, because once you get a doctor, you got to go into residency. So they've expanded the opportunities for residencies in order to try to attract more doctors also. But the real bottleneck, I think, is in the medical schools, is they don't have the openings to create more positions. Now, we did last year, I want to say, or the year before, I think it was the year before, we created a program for nurses in the rural areas that if they go into some of the rural high need areas, that the state will help them pay off their loan or give them loan forgiveness of money that they borrowed to get into that profession. So we've done some of that to try to, because Idaho, downtown here is not that bad, but there's a lot of rural sections of Idaho that really need some nurses. Now, we had a program that I thought was a really good idea, but St. Luke's had the program with BSU that you could go, if you wanted to be a nurse, you could live in the rural area, take almost all your classes and work in the clinic up there, and then maybe for 3 months you would come down to BSU to get your classrooms. So you could stay in your own hometown and eventually get your license to be a nurse instead of having to go off to college. But it was tied directly to BSU and St. Luke's, so that nurse could only work for St. Luke's when they got done. And so that whole, because they had presented the program, now, that's a great program. to be able to stay home, get most of your training right there in the local clinics or local doctors, and then just have to come down. Because what if you're starting a family?
Sure.
And you think, I'd like to get into nursing, but I can't spend 8 months down in Boise or in Moscow or Pocatello. And so this was a program you could do in your own community, but it was a little bit too limited as to who could enroll and who had control over that.
Dang, man, so close.
So close.
So
It was something
close.
good. I even had them because I had gone to BSU and they presented that program, and it wasn't that high of a cost. I thought, that's great. But then they never came with it 2 years ago. And so last year I says, let's research that. Let's draft that legislation. And then we found out that, it was a little more restrictive than what we were. It had to be more broad in order for it to work.
Gotcha.
Because they had the program and the governor never recommended. And I was trying to figure out, why wouldn't the governor recommend that? It seems like a great program for rural Idaho to be able to stay in your community.
Right.
And then eventually end up with a nurse's license.
Yeah. And I mean, obviously there's a juxtaposition between that in demand in the medical field because of limitations with geography and whatnot compared to, say, the launch program, which is like, hey, yeah, we're addressing in demand things, but it is perhaps not necessarily the geography of the school, but the cost of the school and things of that nature. So, interesting stuff. Here's another one, and this is a tricky one as well, tying back to this conversation. Let's make the assumption that the legislature will figure out clarity. We will get clarity from the Ninth Circuit of the Supreme Court, and let's say everything stands as it is. Just for discussion's sake. If that does come to pass, the theory then would be that we would either have that the restrictions on abortions would either act as a deterrent to encourage people to be safer with family planning, or it would cause more babies to be born, or a combination of both, right?
Yeah.
Say some people are more careful and then, or more planned, and then some people
always get surprises.
Right, exactly.
Yeah.
If that's the case, then there is an argument that I've heard that says, hey, look, what if I'm not, like, you've tightened the reins on this. What if I'm not able to care for this kid, right? That's obviously why we have adoption and foster care services, which are done through health and welfare. So in anticipation of this, in a ruling that's more favorable towards Idaho's position, let's just say, is health and welfare doing something to make sure we have the resources for foster care, for the adoption system, for caring for children, that the state is saying, hey, we want to make sure these children are born and not aborted?
That's one of the best things that's coming out so far, because we have a new director. Alex Adams is head of health and welfare, and his focus is on foster care and taking care of the kids. That program has, in my opinion, been in disarray for a lot of years, not been able to get good answers and stuff like that. And so they have now a little card that I forgot to take with me that's a Bill of Rights for children and a Bill of Rights for parents. And so it has like 5 or 6 different bullet points. And so we are trying to strengthen the foster care system and trying to keep families together. There's had to be a fee that you had to implement in order to be a foster care. So they've waived all those fees. So you don't have to pay if you want to be certified as a foster care parent. And so one of the big blow-ups this last year was they were renting VRBOs and putting 10, 15 kids in one house because they didn't have any foster care, any place to put them. And even in talking to some of the people who were doing foster care, they were so dissatisfied with the way health and welfare was running it that they said, I won't do it anymore. I'm just not going to do it anymore. And so this is hopefully to try to encourage more families and more parents to take on the challenge of foster kids. Now, when I came back in the legislature, and that was 14 years ago, I was sat on JFAC. And at that time we had a budget, and we went through the budget on foster care. And the Democrats wanted to add some more money to it, and I agreed with them. But we couldn't get it through the committee. But then about 3 weeks later, they did another supplemental, because I said these foster kids are the most at-risk kids in our society. If we don't put money and don't put effort into them it's going to hurt us down the road.
Right.
So these are the most vulnerable, and I give a lot of credit to parents who are willing to take on foster kids, because sometimes there's a lot of baggage. Sometimes it doesn't show up till later, in life and stuff like that. So it's a challenge, but the focus this year on health and welfare is going to be how to strengthen foster care, encourage more people to take on foster care, and how to support them in that instead of trying to overregulate them.
Yeah, I have several friends that foster children. My dad, in fact, adopted 7 after me, 7 children, and fostered several more. And it is just exceedingly difficult, and it's heartbreaking at times. And again, I think you're right. They obviously, and I don't have to tell you, right, but they're definitely the most at risk group of our population.
Yeah, and so 2 years ago, we passed a bill that, because right at the current legislation at that point was when you're 18, you're out of foster care. So we passed the bill that allows them to stay till 21. Just if the family's willing to keep them, they can stay in foster care till 21. Because 18-year-olds aren't always equipped to make all the right decisions.
Oh, sure.
And if they lose that whole support network or whatever, then where do they go?
Now, when you say you extended the program from 18 to 21, what does that mean? Because if I'm 18,
that means we will continue to support the families if the kids stay there until they're 21.
Gotcha. Because again,
they get some financial support from the foster for taking on these foster kids. So we will continue to support them if the kids stay in that household till they're 21.
Has that been well received?
I think so, but I don't know how many people are actually even aware of it, because we slipped it through really fast at the last minute, so it didn't get a lot of opposition. We ran it in our committee, ran it on the floor, and passed it on through. But I just think, and it was another legislator, my seatmate, who has adopted or has foster kids, realizing that at 18 isn't always, not everybody's ready. Oh, even normal kids aren't ready to go out on their own on 18 and make all their own decisions. You still need a support group.
Right. Even kids with their biological
parents.
parents.
Yeah, with their biological parents, yeah.
Yeah, that's a tough one. So it sounds like the answer is yes, there is more ramping up of the foster system.
There's definitely, that's going to be the focus this year. There's going to be some rule changes. There's going to be different personnel that are going to be in charge of that, and really try to strengthen that, because it was not good at all when you're, and the problem is if you don't have foster parents in Idaho, where do those kids go? You put them out of state, because the state's responsible for them. And so they have a facility now in Payette that can house quite a few. And even just the interim, once the child ends up in health and welfare's custody, it's like, you don't immediately have a place to put them for foster care. And so then you go on and you have a place now where they're all kind of supervised a lot better than what it was before. But eventually you try to place them, families together, kids, siblings together, and or with family, relatives and stuff like that. And but when you get, bottom line is, if you don't have anything, sometimes they end up out of state. And we were getting too many of them out of state or in the just renting houses and filling them up.
Yeah, what a difficult situation. When Kate from Foster and Heart, I came in and did a show a few months back, and she was recounting when she got her first foster child, and it's immediate, right? Like, if something happens, if they go into the custody of health and welfare, they need a place to sleep that night. Yeah. They need food. They need a toothbrush. They need a shower. They need immediate care. And in her case, she was dealing with very, very young children. And it's really interesting hearing her story, because she was at work and she got this call and she just left immediately. She's like, oh, it's go time. We're going now.
Oh, yeah.
And in this particular case, there were, I believe, 4 siblings at the time and a 5th on the way. And she pulled up to, take custody of her kid that she was gonna care for. And 4 kids got out of the van. She's like, wait, which one is mine? And they were all siblings, and they all went to 4 different families. And
that's tough.
Yeah, right. Yeah. And again, those kids, all 4 of them need trustworthy, safe adults instantaneously.
Yeah. But not everybody can handle 4 kids.
Right.
You know, how much room do you have? How many you're willing to take on, you know?
You got to have some bunk beds ready.
Yeah,
you
really do, to get 4 kids all at once.
Yeah.
That's a tremendous challenge.
Yeah. It's a tricky thing.
Yeah.
One last thing. I went down to, there's an advocacy day for the PTA this year at the Capitol, and I happened to be a member of the PTA, and I went on down. It's like, all right, PTA time. And I was like wandering through the halls because I have no idea where I'm going. It was the first time I had been there. And I had done an interview with then Senator Treacle and saw him in the hall. I'm like, oh, I'll just say hi. And a gentleman was talking to him. So I just waited, like, all right, I don't want to interrupt. I had to leave because this guy was talking to Senator Treacle. Like, he was not stopping. And the conversation was all about prescription medications and how, you know, certain insurance programs actually charge patients more for prescription drugs than if they had just bought them straight from the pharmacy or something of that nature. Prescription drugs are always, you know, on the top of everybody's mind, which is, why are we paying so much? How are we paying so much? How do we decrease that? Is there anything happening in health and welfare to help with the cost or curb the cost, ever increasing cost of medications?
We passed some legislation that goes after PBMs.
What's PBM?
Which is prescription benefit managers.
Okay.
So there's 3 major ones in the United States. And then there's smaller ones here and there. What they do is they'll go to a hospital and say, hey, I can get you all of your drugs that you need. You come through me. I can give you discounts. I can help you with this drug or that drug. The cost will be lower. And so the hospitals really like it. They think, I'm saving money. I'm not paying full price on all of these other drugs. But the problem is there's a lot of kickbacks that the managers, the PBMs get, that doesn't necessarily go back to the customers, to the patients. And so we try to put a little more transparency onto how those work and why they work or why they shouldn't work. So there's a lot of, in the prescription, you know, because you can get the same drugs out of Canada for maybe half the cost as what you're paying here.
Right. Like, somebody's making money.
Somebody in between is making, yeah.
So if I'm understanding this right, so a prescription benefit manager shows up to a hospital and says, hey, you're paying $100 for this. If you go through me, I can get it for you for $70. And the hospital says, okay, that's great. But that $30 delta doesn't necessarily go to the patient.
No.
That $30 delta may go to the person who's getting them the lower the PBM, the prescription benefit manager.
Yeah.
So although the hospital is decreasing its cost, it's not decreasing the charge to the client.
It goes back to the patient. And what we've had,
oh my God.
And what we've had before is, so the private pharmacies will get the drugs through these PBMs, and they'll tell you how much they're going to reimburse you for that drug. And some of them, they actually reimburse you less than what the drug cost you. So you actually lose money selling that drug. And their argument is, well, but you're going to make more on some of these other drugs. So in the long run, it balances out. But, you know, try running your business where, you know, I'm paying $80 for this drug, and they're only going to reimburse me $65.
So you're just losing the 15.
Yeah.
You as the pharmacy just lose the 15.
Yeah, you just lose it. No, maybe you make the 15. That their argument is you make the 15 somewhere else. But at the same token, and you don't know what the reimbursement rate's going to be until they decide later. And let's say, and then some of them were doing, well, we reimbursed you $70 for this, but as we got through the end of the year, we decided we reimbursed you too high, so we want another $10 back.
Okay, can you, and again, Matt's an idiot. You got to help me understand this. When you're saying, first off, who's reimbursing the, say I'm a pharmacy and I sell a drug for $100.
So you're getting your drugs through a PBM.
Okay. And the
just
PBM,
like the hospitals.
Great. Are. So I'm selling this drug for $100, and the PBM comes to me and says, okay, you're going to buy this drug from me for $115 and you're going to sell it for $100. And so all of a sudden I'm like, well, wait a minute, that doesn't work because I can't sell at a loss. And he says, yeah, but this is what we're going to do. This other drug over here that you sell for $50, I'll get you that for $25.
Right.
So you'll make up that delta on the other drug.
Yeah.
And so they essentially just make you purchase at a loss, purchase and sell at a loss with certain. Why can't the pharmacies just increase the cost of their drug? Like,
well, the pharmacy, what they get reimbursed for the drug is where they're getting it from the PBMs. What they get reimbursed for the cost of the drug, and they know what their costs are to start with, but they don't always know what the reimbursement was. So we told them they had to be more transparent and have to put out what the reimbursement rate was quicker, so you would know that ahead of time.
So you as a pharmacy could decide whether or not you want to do business.
Yeah, and then a lot of the problems that you have is some of these PBMs will try to put out certain manufactured drugs because their discount is higher on that one as compared to another one.
So like they have a generic version of something.
Right, yeah,
like,
but
go ahead and take this, no problem.
But because I was at a conference last year, I think it was last year, where this doctor says, I had 2 drugs. The one drug cost $1,000. I had another generic drug that cost $100. But it was more expensive for me to give the $100 drug to my patient than it was the $1,000 because I got reimbursed better on the other one.
Gosh, man.
Yeah, so you there's just some of that going on that's really hard to get your arms. And I understand the hospitalists why you want to say, I don't want to negotiate every drug every time. I want somebody to, regulate my benefits, the prescription drug benefits. And so that's why PBM started. So in a way it makes sense, but at the same token, there's just a lot of stuff going on that isn't that transparent. And the doctor says, hey, so my patient, because let's say the patients on that $100 drug had to pay the whole amount, but they got reimbursed on the other one and maybe only had to pay $50. So it was more expensive for the patient to take the less cost drug than it was the more expensive one.
Gosh, man, this is, I mean, if faith in the established medical community wasn't at an all-time low already, when you hear things like this, like we're getting gamed, like patients are getting gamed every day. You can't just say, like you're the one helping
I'm supposed
us.
to stop it.
You're like, yes, that is 100% correct.
It is, and I haven't figured out. We've dealt with the PBM bills for probably about 4 years in a row. Finally got something through. But first one was they just had to register with the state. And now we had a little more transparency in it because it does need, and we're not even trying to regulate it. We're just saying, I want transparency. And so some of the states have said some of the reimbursement or the discount that the PBMs are getting has to go back, certain percentage of it has to go back to the patients. And so I've heard rumors that some of the PBMs moved their reimbursement offshore, so the state couldn't go after their reimbursement rate. It's I've learned a lot, and I when I got on health and welfare, my background is not health and welfare at all. I'm a farmer by trade, and so I've learned a lot in the years I've been on it. Yeah.
God, that is just man, that's something. Anyway, listen, I really appreciate you coming in. I know you just happen to be in town. We've talked about a lot of things. Is there anything we've missed that you want to hit on? And I'm sure we could talk all day about different aspects of this.
Yeah, I really think that when we look at health and welfare, we didn't talk about SNAP people on food stamps and stuff like that. I just think there has to be more oversight, and I don't think anybody wants to not help the truly needy. It's to just try to make sure that's where the money is being spent. Are we really spending all our Medicaid dollars on the people that really need it, or do we, are we spending it somewhere where we don't need? And so to me, it's not trying to get rid of benefits. It's just trying to make sure that I'm spending the dollars wisely, because they are, everybody says, well, it's federal dollars. Well, 70% of it is. 90% of the Medicaid expansion is. But I says, you're either taking out of my right pocket or my left pocket. I pay federal taxes just as much as I pay state taxes. And there seems to always be this plot, well, it's federal money. We don't have to worry about that. And even in the legislature, it's like, well, that's dedicated money or that's federal money. We only got to worry about our general fund money. And I think, when I first came in, Governor Otter said, we have to get less reliant on federal dollars.
Right.
And we have probably tripled to quadrupled the amount of federal dollars that have come in the state since then.
Gosh, that's brutal.
Yeah, we're way too dependent on federal dollars. And I think somewhere down the line, Medicaid expansion is 90-10. I think if Congress ever gets their act together, and that's a big if, but then that reimbursement rate may go from 90-10 back down to the same reimbursement rate as everybody else at the 70-30. And if that happens, then we get hit with so we have legislation that says if it goes away from 90-10, then Medicaid expansion goes away.
Gosh.
Because we can't afford to pick up another $300 million.
Right. That'd be an astronomical paycheck.
Yeah.
Thank you for coming in today. We'll have to make this the first amendment because, again, I actually have a lot of other questions that, again, we just don't have time for today. But thank you.
I don't have all the answers, but I'll make them up as I go.
That's all I care about. Just say something.
Just say something to make it look like we know what we're talking about.
Just make noises with your face and I'm happy.
Yeah.
Thank you for coming in, sir. Thank you for what you do.
All right.
MTU Studios is the proud producer for the Ada County Sheriff Podcast, the Idaho Wildlife Federation Podcast, the State Representative Ted Hill Podcast, the Idaho State PTA Podcast, and many more. If you or your organization is thinking about starting a podcast, MTU Studios would love to help. Just check out mtustudios.com.